Okay, hi, let's get into this question. You can go ahead and pause the video and read this for yourself and try to answer it, but I'm going to go ahead and read it to you and then we'll go through the answer. A 42-year-old woman presents to her primary care physician for a routine checkup. During her visit, her blood pressure is measured at 190/110, but she is asymptomatic. She has no significant past medical history and is not on any medication. Her pulse is 72. Physical examination is unremarkable. She has started on losartan therapy. Which of the following changes is most likely to be observed in this patient following treatment? And hopefully you got to the correct answer, which is D, increased serum angiotensin II concentration, and we're going to go into why that is. So this question is very direct. There's nothing in the vignette that necessarily necessitates you knowing a diagnosis per se. This is a direct, what is the mechanism of action and what is the consequences of taking a drug type of question. So they simply tell us the patient is started on losartan, and it's imperative that you know two things at least in order to answer this question. Number one is what is losartan, so its mechanism of action and what it's used for. Second, you need to know the Renin-Angiotensin-Aldosterone System, also known as RAAS. This is a non-negotiable topic to know, meaning you have to know this for the exam. And that is whatever exam, whether it's step 1, step 2, COMLEX, it doesn't matter. You need to know the RAAS. We're going to go over it in this video, but if you want more detail, there are other resources out there that you can look at. But for the sake of keeping this video short, I'm only going to touch on the topics that are most important for answering this question and answering similar questions as they pertain to the step 1. So like I said, you need to know what the Renin-Angiotensin-Aldosterone System, or RAAS, is, how that works, know it inside and out. You also need to know the drugs that inhibit this system. Okay, so that includes the ACE inhibitors and the angiotensin receptor blockers. Because aldosterone is involved in this system, you should also know what the effects of aldosterone are on the body, okay, including whether aldosterone is high or if it's low. So what exactly is the RAAS for? The RAAS exists to ensure the kidney maintains adequate blood flow. So about a quarter of our blood flow goes to the kidneys, to both kidneys. So they get about 10% of our blood flow each, 20 to 25% total. So they should be equipped with some sensory ability to know when they're getting low perfusion, which they do. That includes the juxtaglomerular cells that sense perfusion, and the afferent arteriole, which also senses the amount of perfusion and then adjusts accordingly. One of the ways in which the kidney will adjust itself to receive correct blood flow is to release renin and begin the RAAS system process. Now, in this particular patient, we don't necessarily know what the inciting event was to cause her kidney to release more renin and then create the hypertension in her. She's at 190/110. But it doesn't necessarily matter for the purposes of answering this question in particular. You might know from your studies that fibrodysplasia or renal artery atherosclerosis can cause the kidney to chronically release renin, which then downstream has the effect of causing hypertension chronically. So then the question becomes, how exactly does renin and the RAAS lead to hypertension? This image is from Wikipedia Commons, and if you look at the left-hand corner up at the top, you will see a schematic of the nephron. So this area is what we're going to look at right now. That's what all of this is. This area that I'm highlighting like this is essentially the area that is going to sense the perfusion and make adjustments. So that area that I was highlighting in yellow, that is the juxtaglomerular apparatus, and that's where we're going to release the renin. So from the afferent arteriole, renin will be released and then come out through the efferent arteriole into the rest of the system. Now, what exactly is renin? What does it do? Renin is an enzyme that will take angiotensinogen, which is made from the liver, and it will turn angiotensinogen into angiotensin 1. So that's what renin does. Angiotensin 1 is then turned into angiotensin 2 by angiotensin converting enzyme, also known as ACE, which is normally found in the lungs. Now, these substances are traveling around the circulatory system, which is why they can reach the lungs in order to find the correct enzyme. Now that angiotensin 2 is made, angiotensin 2 then can go to the adrenal gland cortex, specifically to the zona glomerulosa, where it then binds to what are called angiotensin II type 1 receptors, or AT1 receptors, in the adrenal cortex, and then they will release aldosterone into the blood. So what is the point of aldosterone? Aldosterone tries to increase sodium retention in order to allow water to follow the sodium and then increase blood volume. The purpose of the Renin-Angiotensin-Aldosterone system is to raise the blood pressure because, again, when the kidneys sense low perfusion, their assumption is we have low blood pressure, and we need to increase it because we, the kidney, need at least a quarter of the blood flow. Therefore, at some point, the kidney was signaled to think that there was low perfusion, and then it responded by turning on, so to speak, the RAAS system. So renin was increased, angiotensin 1 was increased, angiotensin 2 was increased, and then aldosterone was increased. When aldosterone is increased, then we increase serum sodium and water. In that process, we actually lose potassium. I'm not going to go into the details of the electrolyte loss or the acid-base balance. That's something that you can look at on your own from other resources. But suffice it to say, the most important thing to know for your exam day, if you know nothing else, is to know that increased aldosterone will lead to increased sodium in the serum, but a decrease in potassium in the serum. Okay, this is a very important point, and if you know nothing else, this is something that you should memorize. Okay, and the reason we have low potassium in the serum is because we are losing it in the urine. As we are pulling in sodium and water, we are exchanging with potassium. The patient was given losartan, which is an angiotensin receptor blocker. And any drug that has the suffix sartan will be an ARB, angiotensin receptor blocker, or an ARB for short. There is another drug that we should be aware of, or another drug class, I should say, that we should be aware of that affects the RAAS system as well. This is the angiotensin converting enzyme inhibitors, or ACE inhibitors, and these drugs will have the suffix pril. So here is a sequential schematic of the RAAS system. Again, starting at the top here, we have angiotensinogen. Again, that's made by the liver. Renin will then come in and convert it into angiotensin 1. Then from the lungs, angiotensin converting enzyme, or ACE, will turn angiotensin 1 into angiotensin 2. Angiotensin 2 will then bind to these type 1 receptors, and these receptors are found in the adrenal cortex, in the zona glomerulosa, and then the cells there will release aldosterone. And once again, aldosterone will, the effect will be to increase sodium in the blood and decrease potassium in the blood. At the level of the angiotensin II receptor, we have the ARBs. So this is where the drug losartan, or any other sartan, would work. And the way to think about it is to consider this forward movement something like a road or a highway where there's many cars going in one direction. If there's any sort of roadblock in this path, then you will have traffic behind the blockage. So it's the same sort of concept. If you block one section of these reactions, everything behind that blockage will increase, while everything forward of that blockage will decrease. So in this question with this patient, we gave them losartan. This now creates a block here at the level of the angiotensin II type 1 receptor. So everything behind that will increase, which means we will have increased renin, increased ACE activity, increased levels of angiotensin 1, increased levels of angiotensin 2. However, after this block, we will have low levels of aldosterone. Now, if we have low levels of aldosterone, we will then have low levels of sodium in the blood, but high levels of potassium in the blood. Okay, because again, we said when we have high aldosterone, then we will have high sodium and low potassium in the blood. Now we have low aldosterone, therefore we should have low sodium but high potassium in the blood. Okay, so with this in mind, and given these points, we can now go back to the answer choices and take a look at what fits and what doesn't. So again, we are looking for high renin, high angiotensin 1, high ACE activity, high angiotensin 2, but low aldosterone, okay? Because this is what losartan is doing. It's blocking our type 1 receptors here. So going back to the answer choices, and again, I've put it here for our convenience, that we are looking for increased renin, increased angiotensin 1, increased angiotensin 2, and decreased aldosterone. And decreased aldosterone would lead to decreased serum sodium and increased serum potassium. So this is what we're looking for in the answer choices. So off the bat, we have decreased plasma renin activity. Incorrect. We said we wanted increased. This is wrong. Decreased serum bradykinin concentration. We'll come back to that. We'll leave that for now. Decreased serum potassium concentration. Okay, so we said we have decreased aldosterone, which leads to decreased serum sodium and increased serum potassium. That's what we should see with losartan. Here it's saying decreased serum potassium concentration. Incorrect. We would expect increased now that we've given losartan. Then D, which is the correct answer here, increased serum angiotensin II concentration. Yes, we see increased angiotensin II, which is what we were expecting, okay, with losartan treatment. So this is the correct answer. Now, let me come back to B, decreased serum bradykinin concentration. The reason they talk about bradykinin is because they're trying to confuse those students who get ACE inhibitors and angiotensin II receptor blocker drugs confused. Okay, so ACE inhibitors can inhibit the breakdown of bradykinin. Bradykinin is a vasodilator. If we inhibit breakdown of bradykinin, which is a vasodilator, we're going to have increased levels of a vasodilator. And in certain people, such as people with hereditary angioedema, which is a C1 esterase inhibitor deficiency, they already have problems breaking down bradykinin. Now, if you give a patient like this an ACE inhibitor, they're going to have even more issues breaking down bradykinin. Now they have excess bradykinin. That's going to lead to extreme vasodilation, which will then lead to extreme edema. This is a side effect that's very much associated with ACE inhibitors, okay, not angiotensin receptor blockers. We gave the patient losartan. We did not give her an ACE inhibitor. So bradykinin has nothing to do with ACE inhibitors. In fact, if a patient needed an ACE inhibitor but they had hereditary angioedema, it would be reasonable to give them instead an ARB rather than an ACE inhibitor. Now here they're talking about decreased serum bradykinin concentration, and you might think, oh, well, maybe we want to decrease the bradykinin and that's why we give the ARB. But the thing is, bradykinin levels should be what they are, either normal or baseline. If you give an ARB, nothing is going to happen to the bradykinin because ARBs do not affect bradykinin. It's only ACE inhibitors that are able to affect the enzyme that converts bradykinin into its metabolites. So this is somewhat of a distractor, trying to weed out the people who are confusing ACE inhibitors with ARBs. So we can get rid of this. Bradykinin has nothing to do with losartan and other sartans and ARBs. The increased catecholamine release from the adrenal medulla. Some students might know that in times of stress, catecholamines can be released. And having the Renin-Angiotensin-Aldosterone system increased is probably signaling to the body that there's some sort of stressor going on. Something is happening. And these reactions don't exist in a vacuum. So if there's a reason to have the RAAS turned on, there might be a reason for norepinephrine or epinephrine to also be released from the perspective of the cells in the body. Nevertheless, this has nothing to do with the losartan therapy that we gave this patient and what the question is asking about. Remember, they said, okay, she is started on losartan therapy. Which of the following changes is most likely to be observed in this patient following the treatment? Okay, so increased catecholamine release, even if that were something to entertain as part of the fight or flight response in this patient, that's not happening as a result of losartan. That would be happening as a result of whatever disease process is going on with her. The body feels stressed for whatever reason, and now this is leading us towards hypertension. We're asking about the treatment. And no, an ARB would not lead to increased catecholamine release from the adrenal medulla. There's no effect like this where the receptor that's being affected, the AT1 receptor in the glomerulosa level of the cortex, that's not going to have anything to do with the adrenal medulla. Therefore, this is also incorrect. And I hope that makes sense. Because yes, catecholamines may be elevated in this patient, but that's not because of losartan therapy. So you have to be very careful. They're baiting a lot of the students who might be confused, scared, rushed, didn't eat during the exam, or freaking out. They're trying to catch us, essentially. And it's important to take a breath, calm down, and make sure you understand what is being asked of you. Okay, so in conclusion, what should you know, what should you memorize, what should you take away from this question and this video? Know the Renin-Angiotensin-Aldosterone System forwards and backwards. Know it very well. Know the effect of aldosterone on electrolyte levels, as well as the acid-base effects. Again, I did not go over that in this video. I don't have time to do that. But in other resources, you will see that in addition to losing potassium into the urine with high aldosterone, we also lose protons, so H+. When you lose protons, it stands to reason then that your serum will become more alkaline. It will become more basic. Okay, so that will affect the pH as well. Again, I'm not going to get into the details, but that's something to also incorporate into your learning. Finally, you should also learn the mechanism of action of the hypertensive drugs, especially those that are the ACE inhibitors and the ARBs. That's easy because their names, their class names themselves are the mechanism of action. ACE inhibitors inhibit ACE. ARBs, they're receptor blockers for angiotensin II, so they block that receptor. That's the mechanism of action. Also, knowing the names, thankfully, is easy in these two classes. Anything that's pril, like captopril, for example, is going to be an ACE inhibitor. Anything that's sartan will be an ARB, like losartan. All right, that's it. I wish you luck, and I'll see you in the next one.